Someone opened a living skull with a stone tool, and the patient survived long enough for the bone to grow back. That is not a guess. That is what the healed edges tell you. So when you ask whether ancient surgery actually worked, the answer is yes, sometimes, and the part that matters is what they were cutting, draining, or removing, and what your body paid to get through it. The baseline problem is this: no anesthesia, no germ theory, no understanding that the thing killing you after the operation is invisible, living, and riding in on the surgeon's unwashed hand. And yet surgery appears anyway, in Egypt, in India, in Greece, Rome, the pre-modern Islamic world. It appears because injury does not wait for knowledge to catch up. Bladder stones, cataracts, battlefield wounds, abscesses with nowhere to go. The body presents a problem and someone tries to solve it with a blade, a probe, a heated iron, or a needle. They had no choice. Doing nothing was also a death sentence. So they cut. The oldest evidence is in bone. Prehistoric skulls from sites across Europe and South America show holes drilled or scraped into the cranium while the person was alive. Some skulls show one opening. Some show 3 or 4, each at a different stage of healing, which means the same person survived the procedure more than once. The bone regrows around the edge in a pattern that takes months, sometimes years, to form. The patient didn't just survive the table. They went home. They kept living. Nobody wrote down why the hole was made. Infection, seizures, pressure, ritual. All of it is still argued. What isn't argued is the healed margin. That part is in front of you in the bone itself. The written record begins to sharpen around 1600 BCE. The Edwin Smith Papyrus, copied from an earlier source, documents 48 cases of injury and surgery with a clarity that still reads as clinical. Fractures, dislocations, wounds to the skull and face. For each case, the Egyptian physician states what he observes, what he will do, and then renders a verdict. Treatable, contestable, not to be treated. That last category is honest in a way that took medicine centuries to recover. They knew the limits of the knife and said so plainly. Move forward, and the procedures get more specific. Cataract couching was practiced in India, described in detail by the physician Sushruta around the first millennium CE, and the procedure was brutal in its simplicity. A needle inserted at the edge of the eye, the clouded lens depressed down and out of the line of sight. If it held, the patient could see. Partially, imprecisely, but enough to navigate a room, recognize a face, not walk into a wall. That was success in ancient terms, not restoration, relief, partial function, the knowledge that you would not go fully blind today. Lithotomy was worse. Bladder stones large enough to block urination were cut out through the perineum, the patient restrained in a position that has no comfortable modern name for it, the surgeon working fast because speed was the only mercy available. Celsus, the Roman medical writer, described the operation in the 1st century CE with the same tone a mechanic might use to describe pulling an engine, step by step, where to cut, how deep, what to avoid severing. The mortality rate was real, and the survivors knew what they had traded, a scar that never fully stopped aching in exchange for the ability to urinate without screaming. The battlefield sharpened everything: Roman military medicine, Islamic field surgery from the 9th century onward, the wound management described by figures like Al-Zahrawi, whose surgical text from around 1000 CE illustrated instruments still recognizable in shape if not in material, cautery to stop bleeding and seal tissue, probing to locate arrowheads or bone fragments embedded in flesh, splinting to hold fractures while the bone decided whether to knit or to rot, amputation as a last accounting, removing the limb to save what remained. The logic was sound. The procedure was what it was. No numbing agent strong enough to matter. Alcohol, opium derivatives, mandragora. They blunted the edge of consciousness, but they did not erase it. You were present for most of what happened to you. And then there is trepanation again, but now as an operation with stakes you can feel. A drill or a scraper working through the outer table of your skull. Then the inner table, with the brain membrane waiting just beneath. Too shallow and you've done nothing. Too deep and you've ended the patient on the table. The surgeons who performed this in the ancient world, and there were many, across cultures that never contacted each other, were threading a gap measured in fractions of a millimeter, using tools that left no room for error and no way to see what they were approaching until they were already there. The skulls that healed are real. So are the ones that didn't. Both categories exist in the same archaeological record, sitting next to each other in museum drawers, making the same argument. Some of them made it. The ones that didn't still went under the tool. Because something had to be done. And this was the something that existed. So the easy reading is this. They were brutal. They were ignorant. They cut people open because they didn't know better, and the ones who survived did so despite the surgeon, not because of him. That reading is satisfying. It is also wrong in the places that matter. Some of it worked, not by accident, not by luck distributed evenly across the population, but because certain methods happened to exploit real mechanisms inside the body. The surgeons didn't have the vocabulary for what they were doing. They didn't need it. The body doesn't require a correct explanation to respond correctly. Take honey, used on wounds across Egypt, Greece, and India for thousands of years. The reasoning at the time had nothing to do with osmotic pressure or hydrogen peroxide or the antimicrobial compounds now cataloged in laboratory studies. The reasoning was observation. Wounds dressed with honey rotted more slowly. Patients survived longer, so honey went on the wound. The mechanism was real the entire time, running quietly underneath the wrong explanation. The wound didn't care about the theory. It cared about the chemistry, and the chemistry worked. The same logic runs through mold applied to infected tissue, recorded in folk practice across multiple cultures long before Alexander Fleming named what he was looking at in 1928. People noticed that certain molds on bread, pressed against a wound, seemed to slow the spread of corruption. They were right for reasons they could not have articulated. The penicillin was there. It was always there. They just found it by watching what happened to the flesh rather than what happened inside the cell. Maggots. Battlefield surgeons from multiple centuries noted that wounds infested with certain fly larvae sometimes healed cleaner than wounds that hadn't been. The larvae were consuming dead tissue and leaving living tissue alone. That is still, in precise clinical form, a treatment used today in wound care. The name for it is maggot debridement therapy. The ancient version had no name. It just had the observation that sometimes the thing you wanted to remove was already doing the removing. Willow bark given for pain and fever. The active compound is salicin, which the body converts to salicylic acid. Aspirin is a synthetic derivative of that same pathway. The Ebers Papyrus, compiled around 1550 BCE, records willow preparations for inflammation. Hippocrates, writing in the 5th century BCE, recommended it for fever and the pains of childbirth. They were prescribing aspirin, not by name, not by mechanism. By result, repeated and recorded across enough cases that the pattern became reliable. Opium for pain. Alcohol to dull the edge of consciousness. Mandragora, the root of a plant in the nightshade family, used as a sedative before procedures. None of these fully remove suffering from the operating surface, but they moved the patient toward a threshold where the body's own shock response did the rest. Partial sedation combined with the physiological effects of trauma sometimes produced a state the patient could survive. Not comfortable. Not humane by current standards. Survivable. That is the category that mattered. Immobilization for fractures. Splints appear in Egyptian mummies. Celsus describes them. Sushruta describes them. The reasoning they gave for immobilization was sometimes wrong. The result was right. Bone knits when held still and given time. That is not a discovery. That is a physical fact that holds whether or not anyone understands why. The surgeons who immobilized fractures were doing something that worked for reasons they didn't fully own, and the bones healed anyway. Here is what Hippocrates actually wrote about prognosis, that the physician who can predict the course of a disease before it unfolds earns the trust of those who are sick and of those who are well. That sentence is not mysticism. It is pattern recognition dressed in the language of its time. The Hippocratic corpus contains clinical observations about wound infection, recovery timelines, and the conditions under which surgery should and should not be attempted, that hold up as observation even now, stripped of the humoral theory wrapped around them. The theory was wrong. The observations underneath were not always wrong. But this is where the honest accounting has to come in. Partial success is not modern success. Ancient surgery more often meant reducing pain to a level the patient could endure, restoring enough function to work or walk or see shapes, buying weeks or months rather than decades, or trading certain death for a chance at something else. The Edwin Smith Papyrus is clear about the third category, not to be treated. They recognize the limits, the romantic version of ancient medicine that surfaces in popular history. The idea of surgeons operating with preternatural skill and achieving outcomes indistinguishable from modern care. That version is not supported by the record. The survival evidence from healed bone tells you someone survived. It does not tell you how many didn't, what they paid in function or pain, or whether the same procedure killed the next 10 patients and was applied to this one anyway. Sample bias runs through the entire archaeological record. The healed skulls are visible. The ones that never healed are also there, in the same drawers, making the same case from the other side. And the procedures that didn't work outnumber the ones that did. Most ancient wound treatment left the patient to the mercy of an immune system operating alone against a contaminated environment. Most cataract procedures eventually failed. Most battlefield amputations ended in what the records call mortification. The ones that survived were remembered. The ones that didn't were buried and then slowly forgotten, which is how certain procedures accumulated more credit than they ever earned in practice. But here is what remains when you strip the mythology and keep the evidence. The person on that stone table, the one whose skull you were watching being opened in the previous section, that person's body was working with everything it had. The surgery sometimes gave it a window, a moment of reduced pressure, cleared tissue, immobilized bone, or blunted pain in which the body could do what bodies were built to do, which is to not stop. The question ancient surgery actually answered was never, can we fix this cleanly? It was, can we make the difference between death today and a chance at something else? Often enough, the answer was yes. Often enough that the knowledge was written down, copied, carried across trade routes, refined by the next generation of people watching what happened to flesh when you pressed honey into it, held the bone still, or let the larvae finish what the wound had started. So ask yourself what is already running inside you right now that works for reasons nobody fully explained to you. Your body did not wait for the theory. It never does. Neither did theirs.